Yes. Thank you everyone for joining us on today's webinar. I'm Charlotte, the Patient Advocacy Manager here at Leukemia Care, and I'll be hosting today's webinar. And we've got a couple of really great panelists who are going to talk to you for the bulk of today's session. End-of-life care is a topic we've not covered in great detail before in webinars, so it's really exciting that we can cover that today. It's a really important area that we hopefully by the end of the presentation you'll realise that we should all be thinking about a little bit more, but also maybe more relevant for some of you in the more immediate future as well, and I hope you find that really helpful. Bit of housekeeping to start with then. So if you are watching us on Zoom, a reminder that you can ask questions via the chat function at the bottom, which is the little message bubble. We won't be allowing anyone to speak or anything, any other mode of asking questions today. If you you can send questions to just us panelists if you want to stay anonymous from the rest of the attendees, or you can share it with all the other attendees here. I would encourage you to use the all attendees function if you feel comfortable, because I think this is a topic where we don't talk about enough. So I think if everybody just feel comfortable to discuss more widely among each other here in this session, that would be really fantastic, I think. And then for those of you watching on Facebook, a reminder that if you did want to ask questions, you can do so by popping them in the chat, in the comment section, sorry, and a colleague will get them to us here in the Zoom call. So without further ado, I'd like to introduce our two speakers for today. I currently can't see them on the screen, so hopefully they'll pop up soon. There we go. Thank you guys for joining us. Julie, maybe you could introduce yourself first for me. You're on mute. There you go.
Hello, my name is Julie Attwater. Hello to everybody. I'm a specialist palliative care sister working in the community, but based at the Macmillan unit in Christchurch in Dorset, which is an NHS hospice, which also has a charity, Macmillan Caring Locally, attached to it. My background is I've been in cancer and palliative care for most of my years of nursing, and that's 43, so quite a lot. And I did 14 years of that in hematology. So I do feel I have a good idea of what journey patients do go on from all aspects of treatment to the end of life care. I work with a team of healthcare professionals, and Dr. Suzanne is one of those healthcare professionals I work with in the hospice, but equally I work with district nurses and GPs and other healthcare professionals in the community to try and make end-of-life care for patients the best we can.
Thank you, Julie, for a very comprehensive overview of your role. That's really helpful, I think. And then Suzanne, do you want to introduce yourself, and then please feel free to go straight into your presentation.
Thank you so much for inviting me. It's a real privilege to talk about palliative and end-of-life care. My background is I'm a consultant in palliative medicine, and I did some of my training up in London in the Royal Marsden Hospital in Sutton, and also at the St Christopher's Hospice in Sydenham, which is one of the largest and first modern hospices in the modern hospice movement. I started as a consultant in Bournemouth and Christchurch in 2015, and it was the thing that attracted me about this particular position was that I got to look after patients in the community, in a hospice inpatient unit and in the hospital as well, and so that I get to follow patients through from between different settings, which is a really wonderful part of my job. So let me see if I can share the slides with you. I'm sure Charlotte will just confirm that she can see them.
I can, yes.
Okay, great. So I was asked to speak about palliative and end-of-life care, and particularly how that relates to patients with leukemia and their families, and try and give people a little bit more of an idea of what to expect and more of an understanding about what palliative care is. Unless you've had direct experience of it, it's sometimes quite difficult to know what happens and what is being referred to palliative care. So in terms of the introduction, we thought we'd talk about who is it for, why should patients want it, and what do we in palliative care actually do? So who is it for? The first thing to say is that it is everybody's business. So it isn't just professionals in specialist palliative care who do really, really great palliative care. It is the GPs, the district nurses, the professionals in oncology and hematology, and actually throughout all the different specialties in the hospital. So it isn't just a specialist subject, and it doesn't just take place in hospitals, it takes place in hospices, and it takes place in the community and people's homes as well. It can include life-prolonging treatment, so it isn't just about end-of-life care. Absolutely, it includes end-of-life care, and that's a big part of our role, but it isn't the only part of palliative care. Palliative care, a definition, it actually comes from a Latin word meaning to cloak. And so it's about cloaking symptoms or hiding them and just providing really, really good comfort care and making sure that people are as free from symptoms as is possible and just getting that balance of the medications right. It also is not just about medicines and about physical care, but about trying to take an approach that thinks about the whole patient as a whole person. And so it's about supportive treatment and accepting that perhaps a condition cannot be cured, but that person can still be supported. I think a lot of people think that palliative care only relates to cancer, particularly when we have things like the Macmillan unit or the Macmillan charity, but actually palliative care is an approach that more and more is recognised as applying to any life-limiting illness. So it isn't just for cancer patients anymore. As I've already said, it takes place in hospices. Often these are independent charities, ours is an NHS hospice, but even when they're independent, the referral route is usually through a normal NHS process, so being referred by your GP or your oncologist or haematologist. The community palliative care nurse specialist teams go out and see people at home and look after people whilst they're outpatients in the community. And they will work alongside the GP and the district nurse in terms of making sure that people's symptom control is really, really good. And then there are also hospital palliative care teams who look after patients essentially just in the hospital whilst they're an inpatient, but they will quite often be involved in the discharge process and planning for things at home as well. Our specialist palliative care service accept referrals from doctors, nurses, essentially all health or social care professionals, but also we do accept self-referrals. So if a patient is really in distress and rings up the hospice and says, this is my situation, I've got leukemia and I'm struggling with whatever it happens to be, maybe pain, then we will just take some details and ask permission to go back to that person's GP and get the background information so that we can, get the referral rolling and start supporting that person immediately. So do bear that in mind as well. Palliative care. It's a really scary word for some people, and I think we have to be really honest and open about that. But I hope that doing webinars like this show that it really doesn't have to be. And actually the whole approach of palliative care is that it's not just about dying, but it really is about living well for as long as there is. And palliative care is getting involved earlier and earlier in patient journeys, to the extent that in some places they've kind of needed a rebranding exercise, and actually some hospitals have renamed their palliative care service the Enhanced Supportive Care Service, just so that reflects the fact that people may not be at end of life, certainly not, or they might actually be receiving very active oncology chemotherapy type treatment and may even be cured, but are struggling with symptoms at the moment that they need some specialist input with. And so that's why people talk about enhanced supportive care rather than necessarily palliative care, but actually they're the same professionals with the same training who are involved. And if it were a drug, it would be worth millions and millions of pounds. hospice. So just to go back and to show that palliative care is not always about kind of death and dying and negativity. And I think people imagine that hospice is a very black place to be. And this is a photo of our hospice in Christchurch, and it just shows that these are two of our real patients. They're in their beds. They've been pushed out into the hospice garden. There are lots of roses in the background that you can't see. And we have this beautiful garden that's entirely done by our volunteers who are amazing. There's a lovely fish pond that their children can run around and love watching the massive fish swimming around. And, you know, it just shows that these patients are in the sunshine, you know, with their relatives and their friends and family, and it's a little bit less like a hospital. So it's a more homely environment. There's a lounge and a place where relatives can make some food and things. So it just is a little bit more of a home from home environment in a hospice. Why should patients want it? So there has been research now into palliative care as an intervention. And initially, the main study was actually done in lung cancer patients, but they've just published a study this year that mimicked the same results for patients with leukemia, specifically with acute myeloid leukemia. And what the original study showed, it was done in 150 patients with advanced lung cancer. And it just compared usual care with oncology, chemotherapy, whatever was recommended, with another group who received oncology treatment alongside palliative care as an intervention early on, sort of from diagnosis of having an advanced lung cancer. And what they found was, it was no surprise to anyone that they found that there was an improved quality of life and they had improved symptom control. But I think one of the reservations that even some healthcare professionals have is that if we talk about dying or that things might not work, then it might shorten the prognosis and the patient will give up. And actually, this study blew that belief completely out of the water. Actually, the patients with an early palliative care intervention had improved survival overall by 25%. So it really makes a huge difference. And so they tried to dig down into why that was. And I think one of the reasons was that actually the people who received early palliative care had had more advanced care planning conversations. And actually what that led to was that they were 90% less likely to have aggressive or invasive treatment late on in their illness as death was approaching. And so 90% less likely to receive chemotherapy in their last 2 weeks of life, and all of the unpleasantness that goes along in terms of side effects with chemotherapy. They had fewer aggressive treatments towards the end of life in the last 30 days. They spent less time in hospital by a third. They had less suffering on lots of measures, including depression and anxiety, and improved well-being for their caregivers. So, as I said, if it were a drug, it would be worth millions and millions of pounds. So talking a little bit about hospice admission, I think a lot of people think of hospices as only for end-of-life care. That is part of what they do, but lots of patients are admitted to a hospice just for symptom control. They come in for anything from a few days to a few weeks, depending on how difficult the symptoms are. And then they can be discharged home, having adjusted the medicines and improved their well-being and comfort. I think one of the things that people feel quite surprised about is that it's quite a small resource. Our hospice only has 16 beds, our neighbouring hospice only has 9 beds. So it's not somewhere that you can go to and just stay at indefinitely. It really is a really precious resource with a lot of symptom control expertise, and that means it's not possible to have long-term care in a hospice. The average length of stay for us is about 2 weeks. That's quite variable, as I say. It can be from a couple of days to a month or two, but the average is really only a couple of weeks. And therefore, what they can't do is caring for stable conditions that the patient isn't really deteriorating, even if they have significant disability, it's not that you can be cared for in a hospice in the long term, unfortunately. So the hospital palliative care team reviews patients in hospital, as it says on the tin. They are essentially an advice service, so they won't take over your care. They will just work alongside the hematology and oncology teams to improve symptoms and quality of life. But they will try and help you plan for the future as well, and offer some of those conversations about what happens next as well. So one of the emblems for our hospital palliative care team is the butterfly. And we use that just to mark those patients that and families particularly who perhaps just need a slightly more sensitive approach, and make sure that everybody on that ward knows that they just need to be really provided with a lot of compassion in all of their interactions because of what they're going through at the moment. And we have this plan about what matters, and we ask what matters, we listen to what matters, try and understand it, and then do what matters. And then that butterfly leads into this wonderful acronym WINGS. So the W stands for what matters to you, the patient, and to those important to you. And then the I is for identify and seeking information about prognosis, if that's what's wanted. And actually, when you do the research and you ask people if they want to know, about 3/4 of the population say, yeah, absolutely, I would really want to know. But that doesn't ignore that important 25% of people who say, oh, no, I don't think I would want to know. So that's why we need to approach it quite sensitively. N is for needs. What do people need to be comfortable? And goals. What is important to you and what is important to those around you? And then the S is for support, making sure that the needs of the family and carers are being met as well. That just gives you a flavour of what the approach is within palliative care. In terms of advanced care planning, the thing that you hear in the kind of general public domain is getting your affairs in order. I think everybody kind of thinks they understand what that means. And most people will think about, you know, have I made a will? And a lot of patients will tell me immediately about their funeral plans if I ask them this question. And they'll say, oh yeah, my family are all taken care of and provided for. Very few patients immediately talk about where they want to be cared for if they're getting less well, or what equipment they might need if they're getting less well, or what their wishes are around resuscitation, which is often a really difficult issue for people to talk about. And then the other thing that people sometimes haven't talked to their families very much about is what quality of life means for them. And I once had one patient who said to me, you know, he was a marathon runner, and he basically said, if I can't run, then that's my quality of life. I don't want to be alive if I can't run. And that's different to me because I am a complete couch potato. And so that isn't quality of life for me. For me, it's eating. And then I realized when I was preparing this talk that I hadn't asked my husband. So I went and asked my husband what quality of life meant for him. And he said, getting into the biscuit barrel. So yeah, that shows you where we are. But in terms of advanced care planning, it's common sense, really. If you express your wishes in advance, you have a much better chance of those wishes being respected. And they've done research to back that up, but it's kind of intuitively true, isn't it? If you tell people what you want ahead of time, then there's a much better chance that people can prepare things so that can happen. But having said that, it's really important to say that advanced care planning is just as unpredictable as birth planning for pregnant women. So, you know, people's condition changes, the situation can change, and people can and do change their minds. That's absolutely fine. But I think it's important to say as well that if it doesn't happen according to the plan, that shouldn't be regarded as a failure. It is just what happens sometimes. And I think that's really important to say to families and to relatives who feel that perhaps they haven't done everything they could have done to support that person. But actually, sometimes given the situation that people find themselves in, it was important, you know, to make a different decision, and that that's absolutely fine, and we can support people to do that too. But the reason to express your wishes in advance are, if you get so poorly you can't be asked what your opinion is, and actually the people taking care of you have a good idea already about what you would say. That's the important thing. In leukemia especially, it can be quite difficult for the hematologists and oncologists to judge exactly what the transition point is over to palliative care from a very active or curative intent to treatment. And whilst prognosis, it is worth saying, is always uncertain, it is guesswork. Hopefully it's educated guesswork, particularly with experienced doctors and nurses giving you a good idea, but it's still guesswork. So there will always be a kind of a variation. Nobody will be able to give you an exact date or an exact time, but it's still helpful to have some idea about what you might be thinking in terms of. And quite often it needs patience to ask before clinicians are willing to open up that conversation. It happens too often that bereaved relatives and families tell us that the end felt like it came suddenly and unexpectedly. And actually, when you tease it apart a little bit more and look back at it, that there were clues, there were hints beforehand that somebody's condition is changing. It just wasn't communicated well. Treatment is sometimes offered, particularly in leukemia, even towards the very end stages of the illness, because it's seen as providing symptom benefit. So if you are feeling like you're not getting benefit from your treatment, it is all right to ask. It's all right to ask if that's the right thing to keep going with it. I'm going to hand over to Julie to talk about the advanced care planning in terms of preferred place of care.
Thank you. So one of my jobs is to talk sensitively to people about where they would like to be at the end of life and where they would like to be cared for before that. And the majority of people express a preference to die at home, but sadly that doesn't always happen, and the majority die in hospital. Particularly in the pandemic, deaths at home have risen only from 25 to 33%, but 80% of bereaved people say that their loved one died in an appropriate place. And that often is because things change, as Suzanne has said. People may think they want to die at home, but actually the reality of facing that and the circumstances of that situation may mean that people change their mind. And so when they do change their mind, we go with that, and that's the right thing at that time for that person. So as Suzanne very rightly said, the plans sometimes change, and that's okay. So there are probably 4 places of possible care. It can be a home, hospital, the hospice, or a care home. And palliative care can be provided in all those settings. Home is often the thing that people choose because it's familiar. You've got your things around you, you've got your loved ones around you. But as people deteriorate, often they need care, they need equipment, they may need medication, and they may need a plan of how we're going to manage things. So my role is to help try and plan for that. And we try and plan ahead of time so that we have things in place when people need them. If people need care, there are 2 types of care that we can access. There's social care and there's health care. And health care becomes accessible as people get more poorly. And that's one of the things we look for when people are deteriorating, so that we apply for that care in a timely manner to enable people to stay where they want to be. We can order equipment, hospital beds, commodes, tables, chairs, anything that might help facilitate that death at home if that's what the patient wants. And we order what we call just-in-case medicines. So they are medications that patients can have ahead of time of needing them, but that they're there when they do need them and they can take them in a timely way, rather than having to wait for out-of-hours doctors to to come and see them and prescribe them, and then have to trawl around chemists to find a chemist that stocks the medication. So we try and order those ahead of time to, again, make sure that the patient dies where they want to die. And we have their preferences for care documented on a special plan. So, for example, with somebody with leukemia, maybe they've decided they don't want to pursue transfusions anymore. And actually, maybe that if they become anemic, they've decided they don't want to go to hospital for a transfusion, and actually managing their symptoms may be a better approach to that. So if we communicate this information to their GP, the hospital, the out-of-hours service and the ambulance service, then anybody that comes in contact with that patient will then know that that is the plan for that patient. And one of the ways that we highlight that there's a plan in place is the use of a lion's pot. We put a sticker on the front of the patient's door. That, to a healthcare professional, asks them to look in their fridge, and in the fridge we have the plan of what their care is, their crisis plan. So everybody will know about that plan, any healthcare professional that goes into the home. And that's one way of making sure that patients get what they plan for. As Suzanne said earlier, patients can die in hospital, and that can sometimes be because it's their choice to go to hospital, or there could be a crisis where there isn't a plan in place and people get admitted, and then they're in an environment where there are staff 24 hours a day, but it's a very busy environment and it's very much dominated by hospital routines. And not necessarily always in a familiar ward. I think particularly with hematology, they do tend to look after their own patients, so that is good, and it's a familiar environment with familiar staff. But that's not always the case, particularly at the moment in these very pressured times. So actually having a think about whether hospital is the right place for you is a good thing. The hospice is definitely an area that people can go to get 24-hour support from staff, but it's a much calmer environment and it's not so led by routine, but it is still a clinical environment. And it, as Suzanne's already said, it's only for the short term, an average of about 10 days to 2 weeks. And really for those patients with the more complex symptom needs, or those patients that are at the end of their lives. And obviously, both hospital and hospice in these very pressured times and the times of COVID, visiting is restricted. So if you're at home, you've got your family around you and they can come and go as they want. But in a hospital or a hospice, that there is limitations on how often visitors can come, which when somebody's dying can be quite difficult. I think as a hospice, we have learnt during COVID and we are perhaps a lot more flexible than we were with our visiting now. The other option is a care home, again with 24-hour support staff, but maybe not so skilled in looking after people as the hospice. But we are able as healthcare professionals to go into the care homes and give advice on symptom management. And I can think of a patient I had recently that actually went into the hospice. We got her symptoms sorted. She was a patient with leukemia. We got things much more stable, and she wasn't well enough to go home, but she was happy to go to a care home. And I visited her there regularly, and she died a very peaceful death there, and with her family around her. So palliative care can be provided in all settings and by all staff, but in the hospice and in the hospital and at home with the expertise of specialist nurses as well.
I'll take over at this point just to mention the issue around resuscitation, which I think a lot of patients and professionals alike find it quite difficult to bring up as a conversation. But by definition, it's a discussion that we can't have at the time. It's got to be a discussion that we have in advance with people. It only applies to resuscitation treatments after somebody's heart has stopped beating and their breathing has stopped, i.e. that they've already died. It does not apply to any other life-prolonging treatments. And it certainly isn't a particularly nice process. It's not like you see on Holby City on TV, where you're sat up with a cup of tea chatting to your friend, 5 minutes later. It's quite an involved process, and you can still be very, very poorly and unwell afterwards. Unfortunately, it very rarely works in the setting of a patient with advanced leukemia, such that actually only 2% of those patients survive to be discharged from hospital. So it really is a very bleak outcome for resuscitation in that setting. When they looked at a study for people who had received resuscitation and then had that situation reversed very quickly, suggesting that probably that attempt at resuscitation wasn't really very appropriate. It was the patients with leukemia who had the highest rate of a change to a DNR, a do not resuscitate status, at 40% rate in that particular study. And only 20% of cancer patients have shared their wishes. So it really is an important conversation to have in advance. You can only have it in advance. And actually, I think people are surprised when they see those figures that actually it's not like represented in the media. So a DNR, or do not resuscitate order, is sometimes called a DNA CPR, or do not attempt cardiopulmonary resuscitation, and it's sometimes called an AAND, or allow a natural death, just because sometimes it's better for people to frame it as something positive rather than always framing it in something negative. I think people feel like they're not being given something that they should have when it's framed in the negative, whereas actually when it's framed in a positive light, sometimes it's easier for people to get their head around. You should be offered a conversation to discuss it. And if you agree that a DNR order is appropriate for you, it's quite important to have a form, both in hospital and at home. It's not a form that you have to sign, but you do need to talk about your wishes around resuscitation with your doctor, whether that's your GP or your consultant. Whoever you've had the conversation with originally, it's really important that you tell your specialist consultant, your specialist nurses, your GP, your family, and if you're getting admitted to hospital, your admitting doctor. I think sometimes people assume that the IT processes in the NHS all talk to one another brilliantly, and unfortunately it's just not the case always. So if it is something that is important to you, that you wouldn't want to have attempted resuscitation, it is important that you make sure that the people looking after you are aware of those wishes. If you don't want to talk about it, that's fine. You can decline to have a conversation, but it doesn't mean that it isn't an issue that might still be relevant. And you probably should think about delegating a decision-making power to a representative, whether that's your wife, husband, son, daughter, or maybe you don't trust any of those people and you actually think that your neighbour down the road knows exactly what you would want and it's your best friend who knows you best. You're the person who can decide who you give power of attorney to, so it needs to be the person that you trust to make decisions on your behalf. If you want to formalise a lasting power of attorney, in England, the law is a bit different in Scotland and in Northern Ireland. So what I'm talking about really only applies to people living in England. There are two types of lasting power of attorney. There's one for health and welfare, and there's one for property and financial affairs. So for property and financial affairs, that's to do with somebody being able to do banking arrangements for you or pay your bills, pay your rent, if you're rendered incapacitated and can't do that yourself. The lasting power of attorney for health and welfare is the one that applies to decisions around your healthcare, but it also applies to things like where you should be cared for, whether that's, you know, going to a care home or being cared for at home. And again, the power of attorney only kicks in after you lose capacity to make those decisions yourself. But after you've already lost capacity, it's too late to fill in the paperwork for the power of attorney. So again, it's something that you really need to complete well in advance. You can do it online without a solicitor, and I've attached the government website there, which has all the information for how to make a power of attorney and what requirements there are for the attorney, or you can appoint a solicitor to help you. It costs £82 for each of the health power of attorney and the property and finance attorney, and you do need both. So somebody with health and welfare can't make financial decisions, and somebody who has power of attorney for finances cannot make your healthcare decisions. So you probably do need both, but they could be separate and different people. And the important thing that I'm not sure everybody realises that it can take up to 20 weeks to register that power of attorney with the Office of Public Guardian, and it's not official until it is registered. So it's not something that you can leave until the last minute. So in summary, it's really important to talk about your illness. There is lots and lots of support available to you, and actually it's only when people understand what's going on for you that we can really make an individual care plan that's right for you and for your family and those important to you. Do talk about your wishes and your future care, and it really helps if you can write it down. It really helps your family, it really helps the doctors and the nurses who are taking care of you. And Palliative Care are here to help you. We're not as scary as you might think. Thank you. We're happy to take any questions.
Perfect. Thank you so much to both Suzanne and Julie for that really interesting presentation. You've covered a massive amount of information there. I hope it was all useful to everybody watching. Just wondering where to go first with the sort of questions I've got. Just a reminder to everyone, if you've got any specific questions, please don't be afraid to pop them in the chat box and we can cover those. I first wanted to touch on something you said fairly early on, Suzanne, in your presentation, about the idea of rebranding palliative care. I think that I found really fascinating, and I wondered whether you had any sort of view on the rebranding of palliative care, if you like. What are the pros and cons in terms of the impact that could have on people's understanding of palliative care? Are you sort of leaning in favour or against that idea?
It's a really interesting question, isn't it? Because for me, I think doing things like this, where actually we open up our own culture, I still think end-of-life care and palliative care has this terrible taboo attached to it. People don't want to talk about end-of-life care and want to shut it away. And actually, if you go back kind of historically or to other parts of the world, it's not like that. So actually opening it up so that people who have a terminal illness feel included in society and feel able to talk about what's going on for them is incredibly important. So for that reason, I don't want to do a rebranding exercise, but equally, I do want to be able to help people. And actually, if it's the only way to get your foot in the door and for patients and their families to accept the help, then I think I'm all for anything we can do to make that journey easier for people. So I feel genuinely torn on that.
Thank you. And Julie, how about you? Do you have any strong views on this particular point?
I agree with Suzanne, really. I think the important thing is getting the word out there that we're here to help. And, you know, all of us that work in palliative care want to help people and want them to point, you know, be able to signpost them to the right people, to help manage symptoms and make people's end-of-life care much better. And we find quite often that people are very scared of seeing us And actually to be able to do things like this is really helpful, because it breaks that taboo and makes us more approachable, which I think is really important.
Yeah. I think one thing that struck me about the particular choice of wording that you showed, Suzanne, was that it focused on the earlier bit. I think the problem with the word palliative is people think about the end of life portion and not about the early portion, but then possibly the enhanced supportive care takes it too far the other way, and you forget about the end of life. And I wondered whether whether we need to separate the two, or whether that would make the job of you and Julie more challenging.
I think I don't know whether it sounds like a flippant remark, but it isn't. I think some of us feel like we need an ID badge that has two sides, and on one side it's got your photo and your name with enhanced supportive care on it, and on the other side it has your photo and your name with palliative care on it. And actually there are situations where your skills can come into their own in both those situations. So when you're going to see somebody who's early in their journey, for whom palliative is just a absolute no, actually being able to go to somebody and say, hi, I'm from the enhanced supportive care team is a really helpful way in that it doesn't feel immediately like somebody is going to feel very, very anxious at just on meeting you. Whereas there are other people who, you know, they know exactly what the score is. They want it to be open, they want it to be honest, and actually it's quite liberating to be able to talk openly with somebody about something that other people can find quite challenging.
Yeah, absolutely. And how about you, Judy? Do you think enhanced supportive care and sort of splitting the two is helpful?
I think in the years that I've been doing palliative care, I think things have changed. We were very much involved at the end of life when I first started out in palliative care 25 years ago. And I think we now dip in and out as we're needed. So quite often we might get involved for symptom management and then pen the patient for a little while. So it's essentially what we're talking about, but it's not labelled or branded like that. So we don't necessarily keep all our patients on our caseload. If things are stable, we might discharge them for a bit, but that we know about them, and when we need to get involved with them again, we can do. But actually we want them to get on with their lives. If they're feeling well and they're doing well, that's good, isn't it? And actually it gives us more time to help other people. So I think that there is a part to play in you know, being supportive to people. And obviously with treatments getting better, people are living longer and living with cancer much longer than they ever used to. So I definitely feel that there is a role for that, yes.
Just listen to what you're saying there. Do you have an idea of, I mean, if you haven't got specific numbers, that's fine. I was thinking the percentage of people that you do meet sort of at diagnosis or just after diagnosis all the way through to end of life, versus the people that you see a bit later on, and would you like to see more of them earlier? I understand what you're saying about those who don't need a support can get on with things, but would you like to at least introduce yourself at an earlier stage, Julie?
I think we have to be realistic about what we are able to do,
Yeah.
because obviously resources are limited. I certainly in hematology and working in a hospice I worked in Hampshire, I actually did used to go to the hematology clinics, and I would see those patients and meet them before they actually got to that end stage. So actually when it became time to refer them to palliative care, they were very familiar with me and it wasn't such a big deal. And actually then I could do my bit, but realistically, you know, being able to be in every hematology clinic in the country is not realistic. But yeah, definitely, I think if we are able to, if we had the resources to do that in an ideal world, I think that would be brilliant, because it would be less scary then for people.
Yeah. How about you, Suzanne? Is it different from a doctor's perspective?
I think it's very similar. I think we all share the anxiety that we're going to say, yes, we want to be involved with everyone, and then suddenly find that actually we're too stretched and stretched too thin to really do the job well. So I think we probably need more investment and more resource into palliative care services to be able to provide the right level of enhanced supportive care. But, you know, the research is really, really telling in that it does change outcomes for patients. It transforms what can be a really unpleasant experience with too many invasive treatments and tests and focus on all the wrong things, and transform it to something that, you know, is that patient having what matters and creating really precious memories with their loved ones. And actually that is what this should be about.
Absolutely. I found that study fascinating. The link to improved survival was really interesting for me, not something I was aware of. The lung cancer study, is that something that was sort of at the first of its kind? Has it been expanded into many other areas, or does it just need to be?
It is, you know, the lung cancer study is known as the TEML study after the main researcher who was the main investigator, and it's just being repeated in all of the other cancer types. So, you know, it's been repeated on all the kind of solid organ cancers, and now just this year we've got this study published in leukemia and acute myeloid leukemia that it's just repeatedly demonstrating the same things, really, that patients had far fewer invasive things done to them and far less time in hospital during their last month from having early palliative care than without it.
It's good to know that it's being repeated. I think there are always some nuances between different cancer types, but good to hear that it's also making a difference there as well. So we've had one question come through, which I'm keen to make sure we address. Someone's asking how the route that they should take to ensure that their wishes are respected. So the person's talking about how they would like to refuse more treatments, and they already know that they would like to refuse transfusions. Suzanne, would you mind commenting first? Do you have any specific advice for a route to ensuring all of this happens?
Absolutely. So there's a number of different ways that you can do it, actually. If you want to formalise it and make it a kind of legal obligation on the people caring for you, you can do what's called an advanced decision to refuse treatment, or ADRT, and that can be drawn up with a solicitor. But obviously the most important thing is making sure that everybody knows it exists and knows about it. So one of the less formal ways is that you can do an expression of wishes, and actually on the paperwork for power of attorney there are spaces for you to complete expression of wishes and to fill in specific types of treatment, for example a transfusion, or perhaps it's not wanting to be put on a ventilator with a tube down your throat, on a breathing machine, or whatever it happens to be, and being able to say this is not a treatment that I would want to have. And whilst it isn't a legal document in the same way, actually it's in some ways it's much easier to be shared with the people who are doing your care. And actually the most important thing is no doctor or nurse wants to do something that's against a patient's wishes. So really the thing is making sure that you've told people in advance and that that's been documented. And there are all sorts of planning ahead documents that you can find online, and get in contact with your local hospice to find what the local documentation is. A lot of places in the UK are using what's called a respect document, so all capital letters, and that's a kind of planning ahead document that just helps to guide you through the kinds of treatments that you might think about. So whether you want to be admitted to hospital for intravenous antibiotics, or maybe you'd rather stay at home and just try the tablet antibiotics, or maybe you feel that actually you don't want any kind of treatment at all, and that actually you'd really just want to be, that all the focus is just to be on comfort. Or you might feel the opposite. You might feel that actually you really want the transfusions to continue as long as you can, and as long as you feel better with them. So I think it is helpful to write these things down and to give people looking after you a better idea about what you want.
And is there any sort of limitations to those documents? I'm thinking specifically types of treatment. Are you able to say any type of treatment that you don't want, or are there certain things that just can't be planned in advance like this?
So I think you've kind of hit the nail on the head. Is actually I don't think that's a problem with the document. It's actually a failure of our imagination. We are very bad at imagining what we will want in the future. You know, whether that's a very trivial thing or whether that's a really important decision. We're really bad at knowing how we're going to feel, and that's why people need to be able to change their minds. And sometimes that's why I think I would almost favour having a really open, frank conversation with your spouse, or you know, whoever is your next of kin, son, daughter, whoever it is, whoever's important to you, and having a detailed conversation about what your feelings are and what are the things that matter. And actually that then enables the doctor to look at what the treatments they're thinking about are, and thinking, well, actually that wouldn't achieve what that person thinks is really important, or that would, that is the one that we should go for. And so actually in some ways it's more helpful for the doctor and the healthcare team to have that idea about what are the things that matter to a person, rather than a specific, you know, I don't want ventilation. Okay, that's fine. But now we've got this situation where actually I need to make a decision about a completely different treatment, about chemotherapy, that has nothing to do with that. And actually this doesn't really inform what the person would want. So I think it is helpful.
Helpful to say both what you want and what you want to achieve, by the sounds of it as well.
Absolutely.
Great. Okay. And Julie, the person asking the question seemed taken with your phrase that you used, where you said a peaceful death. And is there anything you'd like to add to what Suzanne said to help the person get to the point of a peaceful death, whatever that might mean for them?
So that would be what we would all be aiming for, is to try and make somebody's death peaceful. And one of the ways we do that is by assessing them, making sure that they have the medications in place to give as they need to, making sure they've got the contact numbers for people that they need to get hold of to give those medications. You know, out of our contact numbers that they can phone and talk to people if they're struggling. We have a 24-hour duty nurse line where people can phone in with a specific problem, say their pain has become worse, they've tried a medication, it hasn't worked, so they can phone in and talk to us, and we can say take more of this, or phone this person and ask them for this injection. You know, all those things, it help make that person more comfortable. Because, and the other thing is, I guess, because we're working in this field, is we tend to know what things are likely to be a problem, and we try and anticipate problems and make sure we've got things in place to prevent there being problems, so so that, you know, we have a problem-free journey. That would be what we're all aiming for.
Great. We've talked a lot today about documentation and various ways of sort of writing down what you said, and I was intrigued by the lion's pot that you mentioned, Julie, and I wonder whether that's something that you can also set up for yourself if you wanted to. If someone really wanted to sort of be ahead of the game and wanted to put all their documents in place, is that say an ambulance may be called for any reason, is that something somebody could do themselves as well as with someone like yourself?
Yeah, absolutely. And I think they are available. Well, they're certainly in Dorset. I can't speak for other parts of the world, but I know they are in Hampshire as well, because I've worked in Hampshire. But they are accessible from general places like the post office, the chemist. They're a little white pot with a green lid, and inside that pot is a sticker that you stick on the front door, which highlights to the healthcare professional that the pot is in the fridge. And then you put your plan in the fridge. A lot of people use them for medications, or if they've got complex medical histories. It just helps inform the paramedics or the doctors coming out to them about what's going on. Because often if you're unwell, you're not able to communicate that to people. And if you've got no family around, it just helps in the decision-making process, really.
Absolutely. That was going to be my next question, if I may direct it again to you, Julie, is did you have any other advice for people who may not have support mechanisms in place, family and friends? And other than the Lion's Pot, is there perhaps any other advice that you'd give to those people in terms of how to plan ahead and make sure their wishes are known?
So talking to their GPs or the healthcare professionals that they're involved with, they, certainly the hematology patients should be able to speak to their consultants or their specialist nurses in the clinics, and they would be able to help signpost them or help them formulate plans so that, and then communicate those to other people. And despite having problems sharing information in the past, we are beginning to get to a point where things are finally getting shared with other teams, and it does certainly make life a lot easier for everybody involved. Fairly recently in Dorset, we've been able to see what the GPs and the district nurses are writing on their case notes and the hospital notes, so that actually, if you're going to see a patient and they've been to clinic and they've had bad news, I can prepare myself before I go to see them of what's been said and help discussion around that and help them talk about the difficulties maybe that they've just had shared with them, and it just makes everything more supportive. Blood results maybe have been taken and they got to, or a scan where people are waiting weeks to get the results for. If we can help relieve some of that anxiety, that's something that we can do sometimes for them. So sharing information is getting better within healthcare. It's by no means perfect, and I think we've got a long way to go, but talking is good.
Yeah. In the meantime, certainly sharing it with as many people as you can, I'm sure, is the important bit. Absolutely. A few questions just about whether there are any specific challenges to hematology, and either of you able to comment on that. I guess palliative medicine is a speciality in and of itself, and that obviously is your area, Suzanne. But do people, doctors or nurses, sort of specialise more into certain types of either cancer or certain types of cancer within that? Is that something that people should expect, or does that not tend to happen?
It doesn't tend to happen very much. I mean, there probably are palliative medicine physicians with a specialist interest in X, Y, or Z, but I think the majority of a palliative medicine physicians like me would feel entirely confident managing, any condition that was life-limiting. So that's what we're trained to do.
Great. I just thought that would be a useful point to clarify. That being said, is there anything specific that would mean that the condition you have would change any of the advice you've given today? And I know that's a very broad question, but for example, are there guidelines on the care of certain patients with a certain disease at the end of life, as there are guidelines for how to care for a disease when it's not considered terminal? Does that happen very much?
So a lot of conditions will have their own guideline, which will include the end stages and end of life care. So, for example, there is a specific guideline that applies to heart failure, and there's a specific guideline that applies to pulmonary fibrosis, for example, and all of these things include a part around delivering end-of-life care in patients with that condition. Similarly, there's guidance for people who have diabetes and how that treatment needs to be adapted as people's prognosis gets shorter. So that's one area where there's a specific guideline for a specific condition. Does that answer the question?
Yes, I think it does. I think when you have a specific condition, you're quite used to the guideline. A lot of our patients are very familiar with the guidelines and the best practice and things around their care. So I thought it was just good to clarify how your particular speciality would work. I guess the follow-on and question from that is how closely you as a doctor work with someone's hematology doctor. Would you expect their existing care team to be involved right up to the end of their life?
I think sometimes hematology doctors feel that their expertise is very much in kind of chemotherapy, and so if people are getting to the point that they're no longer having chemotherapy, then actually they feel it's kind of right to hand over care at that point. Having said that, I think for patients who are still in hospital and have been in hospital for whatever reason, under the hematology doctors, I think they quite often have got to know that patient over a really long period of time, and it's really difficult and would be wrong for a different team to just come in and take over, if that makes sense. So I think the important bit for me is making sure that patients never kind of feel abandoned. I think sometimes you have patients that really feel that, you know, they've been discharged from oncology because they're no longer having active chemotherapy type treatment, but perhaps for whatever reason they've not felt like they've been picked up by another team, or perhaps not by their GP. So I think if patients are feeling like that, I think it's really important to reach out and to make contact with the GP and maybe get a referral to palliative care, so that there is somebody who is kind of looking after the comfort and the medical side of that advanced condition, because sometimes things can be changing quite quickly, and actually unless you've got somebody who kind of has gotten to know you a little bit and has followed things through, it can be quite difficult to pick up on the cues that things are changing for that particular person. We were talking, Julie and I, just before this about how do you know when somebody is reaching that palliative stage, particularly for patients with leukemia. And I think one of the things that we kind of think about and look at is people who are getting more and more frequent infections, having antibiotics and treatment, but actually are not getting very much benefit. They're just not responding to kind of antibiotic treatment, and the infections are getting more and more closer together. Is a bit of a warning sign sometimes for us. And then similarly with the transfusion, so sometimes people are kind of needing a transfusion every month or every couple of months, and it gets, you know, the requirement for transfusion gets more and more frequent, so they might start needing it every week or whatever it happens to be, and that kind of goes on for a little while, and then they find that actually they're just not feeling any better after each transfusion. And that for me always really raises alarm bells. If somebody is kind of has got to the point where they're needing very frequent transfusions, and then those transfusions aren't doing what they used to do, I always feel worried for that person at that point.
Thank you. And I spotted a question in the chat, but before, I just wanted to sort of finish this section. Julie, I wondered whether you were aware of any specific barriers to some of those choices about where people go in relation to hematology. And I think I've read somewhere about somebody who came to us at Leukemia Care, but had trouble making that choice about where they wanted to go at the end of their life because their transfusions were hospital only. So are there any barriers that can make that choice between hospital and hospice and care home more difficult?
I guess there are, particularly at the moment with COVID and everything being so stretched. It wouldn't be fair for me to say otherwise, because we know that, as we've all seen on the news about the social care issues, carers are few and far between. But having said that, most teams will go the extra mile for somebody that's dying. So district nurses, although providing personal care is not part of their role, if they know that somebody's poorly, they will go the extra mile to keep them at home if that's what they want to do. And between us as a team, we will alternate our visits so that we're all making sure that somebody's going in regularly at a regular time, and not, I wouldn't necessarily perform care, but if there was a need, for example, I had a patient a few weeks ago, we needed 4 carers to move him, and the reality was that just wasn't available. So what we tried to do was schedule our visits so that one of us in our extended team was there to help the existing care team to enable that to happen. And he actually died at home, but it could have been, it was that close to him going into hospital. So people will go the extra mile for poorly patients, and that's what I like about palliative care, because most of us that work in it, and the extended teams that help us, we want to get it right. We only have one chance to get it right, and we want to get it right for patients. Other barriers, I'm sure there are any. My mind's just gone blank. Can you think of any, Suzanne?
I suppose the one about transfusion is an interesting one. Certainly it's not a barrier to being in hospital. It's not a barrier to being in hospice. I don't know of any care homes that can offer transfusions, and I'm not really familiar with people having transfusions at home. I think it probably is a little bit too much of a risky procedure to consider that. So I think, that is one of the things, isn't it, is actually going up to the hospital for your transfusions can be quite burdensome if you're kind of getting weaker and getting much more tired. Then actually that can become a huge burden for some patients.
Travel is one of the things we hear is most annoying about having leukemia in general, from patients. So I'm sure it's much more challenging for people once they reach to the end of their life. So to the question that's been placed in the chat box, then the question is, I think I'll pose it to you, Suzanne, if I may, first. The person says, what drugs are commonly used in the end of life, and what sort of thing do you have in your arsenal to make those for the last few months, I suppose, or however long it is, more comfortable for people?
So I suppose the first thing to say is we have a very big cupboard, so it's not just kind of, we don't have access to any of these 4 medicines, but we do tend to recommend, when we do just in case medicines, the same 4 medicines for the majority of people as a kind of first line just in case, on the basis that we would rather people had something that they might never need, and lots of patients never need anything. That's fine, that's brilliant. But if you do need something, then you want it there, and you want it there immediately without having to wait for a prescription and then wait for a pharmacist and then wait for a nurse to come and give it to you. You really want to be able to have that comfort and that dignified care as quickly as possible. So we tend to make sure that there is something available to treat pain if that comes up. We try and make sure that there is something available as an anti-sickness, so something available for nausea or vomiting. We also try and make sure that there is something available as a kind of sedative, just in case somebody feels anxious at all, that they can have something just to help them get some sleep as well and some rest. And we also try and make sure that they have what we call an anti-secretory, so that can help to relieve kind of tummy cramps, and it can just help people if they're kind of having trouble managing the saliva in their mouth as well a little bit. So we try and make sure that all of those bases are covered. Luckily, the pain relief medicine tends to be morphine, or one of the medicines a bit like morphine, is also quite useful for breathlessness as well. So those 4 medicines tend to mean that a lot of the common problems that people might get are covered. Having said that, everyone's an individual. There's always going to be something that perhaps you haven't thought of, and we can respond very quickly when there are things that come up that we didn't anticipate.
I knew I was going to forget to unmute myself at some point. Thank you, that was really helpful. Interesting to know that it's sort of based around those 4 medicines and that they do different things. I didn't know that morphine did that. That's really interesting. Someone has is listening, is actually a nurse in hematology and has just been promoted to a clinical nurse specialist. Well, congratulations. They're asking, I guess, about resources for healthcare professionals to help them have these sort of advanced care planning conversations with sort of before you guys perhaps are able to get involved. Are either of you aware of resources for healthcare professionals in this area that we can share?
So I think one of the things is there are some really good resources out there around advanced communication skills. So I think an advanced communication skills course is one of those things that I just think everybody should do. It's just so incredibly helpful. And I think, you know, even people who are quite experienced in working in this area actually should do a refresh course every so often just to remind ourselves. So I think that's one thing certainly to think about. I think in terms of the question about how to start conversations, I think everyone struggles with it a little bit. I think sometimes people do wait for the patient to bring it up, which is probably not recommended, but it's totally understandable if you're trying to strike the right note in a consultation. Just bringing up kind of end of life is a really, really difficult thing. But actually one of the things that I think makes it much easier, and actually when you ask them, the majority of patients expect their healthcare professional, their clinician, to bring up the difficult issues rather than being expected to be the one to ask the question. And so sometimes I do just, if it does feel like it's a bit of a change of pace in the conversation, I will just kind of say, would it be all right with you if I raise a really difficult topic, or we talk about something that's a bit more challenging? And that just gives the person a little bit of a minute to kind of gather their thoughts. It also gives them the option of saying, no thanks, I'm not ready for that. And that's absolutely fine. But it just kind of just gives people a little moment to kind of still themselves and think about, okay, what is this going to be about? And then you can kind of get on to those conversations, whether it's around resuscitation or whether it's around a more detailed advanced care planning conversation and kind of, you know, what people's wishes are and where they want to be cared for. But it is just about trying to, I suppose, just open the door ajar and see if somebody wants to walk through.
Julie, anything you want to add? Obviously you are a nurse, so any advice for this newly appointed person?
In terms of all sort of palliative care, there's a really good resource online called ELCA. It's little e, then capital E, LCA. And you can access it as a healthcare professional. All you need to put in is your PIN number, and then it will give you an access to a wide range of resources in symptom management, in communication skills, and it's interactive, so it's really good. And also in advanced care planning as well. So, you know, it's a really good resource, and it issues you with a certificate to show that you've done it at each module that you do. So you can build on your knowledge base and inform yourself. Yeah, it's really good. One thing I wanted to say with regard to the last question, we talked about the drugs that we have at the end of life, but it's very much a holistic approach. And it may be that we use things like complementary therapy, talking therapies. We may get the chaplain in. You know, it's not just about medications. There's a lot of non-pharmacological things that we use to manage symptoms. And I think it's really important to remember that, because we're very quick to reach for the medicines, when actually sometimes just spending a bit of time with somebody and talking to them can make a huge difference. So I just wanted to say that. I'm sorry to sort of add that on.
Thank you, Julie. That's really, really important point. Thank you.
Yes, definitely. Yes, and I think there's a well, from my sort of outside point of view, I think there's been quite a lot more research into the usefulness of some alternative things to medicine in pain relief and things like that. I think it's becoming recognised as a potential area of research a lot more. That's as my knowledge of the area anyway. I have one last question to pose to the panel. So if anybody has any questions that they were umming and ahhing about asking, now is your final chance to ask them. Please do pop them in the chat box or on the Facebook comments. I've lost my question. Yes, it was sort of related to COVID, which I don't like to dwell on too much when we're not specifically talking about COVID, but I wondered whether either of you felt that the pandemic had had any impact on people's willingness to have these conversations around death and dying. Obviously you work in an area where people have to have those conversations, but I'm just interested in your views on that. Maybe Suzanne first.
I think it probably has had an impact to a degree. I think some of it's been quite negative though. I don't know whether you remember at the very beginning of the pandemic, there was this thing in the news where people were kind of being sent a DNR form kind of decision in the post without any kind of conversation, as a kind of blanket thing, which just feels so completely wrong and wrong way of going about everything. Although I think, you know, it's so hard, isn't it, in a pandemic, because everybody kind of loses their head a bit. So in some ways it probably did make people think about, you know, the threat of COVID in a different way. But equally, I don't know whether it's necessarily changed a willingness to talk about it openly as a culture, particularly. I don't really see that, and I certainly still don't see people as willing to really grasp the issues and talk about things in advance in the way that ideally we would like people to plan ahead. But that's hard, and it's natural to put things out of your mind and put it on the back burner.
Yeah, perhaps the opportunity is yet to come, since we are still very much in the midst of it. At least I hope that's the case. Somebody needs to grab hold of the opportunity. Julie, anything you wanted to say on that topic at all?
Yeah, I think from my perspective as a community nurse, certainly patients did not want to go to the hospital, and neither did they want to go to the hospice. They very much wanted to be at home. And as a result of that, it enabled you to have more conversations, probably conversations that you would have had, but maybe you were having them earlier in their trajectory because they needed to have those plans in place to stop them going to hospital. So I think it changed it from, definitely as a team, we were very much trying to keep people out of the hospice and hospital, and using the resources that we had in the best way possible. So we actually did a lot more telephone consultations, and actually a lot of what we learnt was that we can do a lot of initial assessments over the phone and prioritise the people that we need to see, to give that our priority to them. When some people are fairly well, we can manage the symptoms because jiggle around with medications and things over the phone. So it's changed our practice quite a lot, actually. But from a conversation point of view, I think it just brought forward those conversations to stop people going to hospital, really.
That's really interesting, thank you. And I don't think your team is alone in the move to telephone and video and all that. And I think there's a lot more, we're going to be seeing a lot more of that from now forwards. Thank you both for really, really fascinating conversation. It's been, it's been nice to talk about a topic that we just don't talk about enough. As a charity, we recognise that, but also as a society. One thing I did want to say before I quickly go on to the slides was, I don't think we've included this in the slides, which I wanted to mention, which is why I wanted to mention it now. If anybody's looking for resources on how to make any of those documents that we've discussed throughout, I'd recommend Compassion in Dying. I've used it personally. It says there's another charity that advocates for people expressing their wishes around dying, and they've got some really good resources there, and they've assisted us in the past as a charity to understand the process around end of life. So Compassion in Dying is a really useful resource, and I will post that in the chat box now before I forget. Back to us here at Leukemia Care. If you're looking for more support and information, we've got a variety of different services that you may or may not be aware of. We have another webinar, one more before Christmas, and plenty more planned for the new year, so do keep in touch with those. Our most recent copy of the magazine with a lovely Christmassy picture of the staff on the back is available now, and do get in touch if you don't have access to that. But we also make podcasts where we tell stories of patients affected by leukemia, which are really heartwarming, so please do have a listen to those if you're looking for something to listen to while you do the dishes or something like that. Would recommend that. Next slide, please. We have a booklet on end of life and leukemia, which is focused around the patient's perspective of facing the end of life following a leukemia diagnosis. So if you're interested in that booklet, you can download it, or any of our other booklets, from our website at the link there, where you can also order a hard copy if you need to. Next slide, please. Just wanted to mention that we do offer a complimentary will writing service. I know a will is just one of the many documents we've talked about today, but if you are interested, and there's no obligation to make a donation to Leukemia Care, although obviously we'd be very grateful if you did choose to do that. But you can find out more about that free service on our website at the link there below, or just search for wills. In terms of support for the topics we talked about today, or any other topic, we've got a variety of ways to get in touch with us via the helpline, with other patients via support groups and online forums, with professionals if you need that via the counselling fund. There's a variety of different options there. Please do use them if you feel you need them. Next slide, please. One particular one that may be useful here is our Advocacy Caseworker service. So we actually just did our last webinar on what is advocacy. So if you're not sure what we do in the advocacy team, I would recommend our last webinar, which you can find on YouTube. But essentially what we can do is help you understand your rights to care and how to address any challenges you're facing with your care. So do use us as a sounding board. That's what we're here for, and you can get in touch with us online or just by calling the usual helpline number. Next slide, please. Our next webinar is next Friday, last one before Christmas, and talking about making the best of your CLL medical appointments. A couple of familiar faces from our support groups and also our webinars. So I'm really looking forward to that webinar. It should be really exciting. Next slide, please. Here's just all our social media pages. I would recommend our Twitter in particular if you want to stay in touch with the latest on COVID announcements and what they mean for leukemia patients. We do our best to keep up with those as best we can and post them all on Twitter, as well as sending them out through other methods. Next slide, please. I'll just leave our number and our email up while I say thank you again to our speakers for today. Really, really grateful for your time and your expertise and all the work you do in your day-to-day jobs as well. Thank you for supporting patients. Yes, but thank you for your time, and have a lovely evening, everybody, and we'll see you on the next webinar. Goodbye.